Good morning. We're going to change focus quite a bit, and we're going to talk to end of life and conflicts. Now, those that have been here previously knew that I talked about a situation with my dad and very bad end of life communication. So I've changed that, and I now have a different case, which I think is quite revealing. So we're going to talk about management decisions in perioperative care of a complex surgical patient who was quite clear about what he wanted and what he didn't want. And we're going to talk about how to manage some conflict. And again, I've always included additional slides that I think are beneficial. So let's talk about this patient, and we're going to work through this case and some different aspects to consider. It's a 74-year-old patient with metastatic colon cancer presenting with abdominal pain, nausea, vomiting, and obstipation. A small bowel obstruction is diagnosed. He's admitted to the ICU for resuscitation, electrolyte correction, and monitoring. In addition to his acute problem, he also has OSA, diabetes, hypertension, chronic renal insufficiency, stage 3A. He's coherent, but he states very clearly that his youngest of 3 sons is his healthcare advocate and should be the one to make decisions. He, however, the patient is very clear that he's willing to undergo short treatments, but he is not willing to undergo dialysis, extended mechanical ventilation, or CPR. He's in pain, and he wants that to be the focus of his care if he cannot be cured. His pain worsens, suggesting a perforation has occurred and surgery is offered. The patient is competent, so he agrees to surgery, but he reaffirms that he does not want CPR, does not want it in the operating room, and his son has been witness to this discussion. So how does one proceed? How does one proceed if you're the surgeon, if you're the anesthesia provider, if you're a nurse? How do you proceed at this point? Well, if you're not aware that the patient has the right to make autonomous decisions, you certainly should be. And policies that automatically enforce or cancel pre-existing DNR orders for procedures do not sufficiently support a patient's right to self-determination. Physicians should discuss and document a DNR status and whether or not there is a change to that status for a procedure. Now, options include suspending the DNR for a specific, sometimes short period. 48 hours is fairly common. It's also possible to continue the DNR in the perioperative period and limiting it to specific interventions that are discussed with the patient ahead of time. If, of course, a healthcare provider has an ethical or professional conflict, an alternative provider should be recruited. That is, if the DNR stays in effect in the procedure. So we know that CPR, when its history really was not intended for the situations that it currently is performed. It really was to resuscitate from an acute problem, and it was expected to be successful, not a way at the end of a certain life. So what happens in your unit? I would say if it is D or E, you have some work and reflection to do at your institution. So let's talk about the rest of this case. The patient goes to the operating room and the DNR has been suspended. A perforated small bowel is found. There's a large amount of contamination and carcinomatosis is identified. Additional family members arrive. That includes 2 older sons and a sister, as well as cousins. The family members are very concerned and insist that the patient is a full code and that everything and anything should be done. At this point, the patient has lost capacity. What are the options at this point? A very insistent family. I'm sure some of you have come across this. I can tell you it is not at all uncommon in my practice. So first of all, how do you determine if someone has capacity? They must have all four of these things. They must understand, they must appreciate how the information applies to themselves, they must be able to express their choice, that they have made a decision, and it should be based on reasoning or the ability to compare the information and the consequences of their choice. So that's what a patient must have, all these things to have capacity. So what are the options here? Well, some might say you need to respect the family's wishes, that is, the older sons and the rest of the cousins. We know that death and dying is very personal, often cultural, and very profound. We also know that families are not always on the same page, and there can be very complex family interactions. And you would think in some circumstances, assigning the healthcare advocate as the youngest son might suggest that there are, in fact, complex family interactions. Is it possible to follow the family wishes, but behind the scenes focus mostly on pain and suffering, which the patient was very clear about before they lost capacity? Should you just give time for the healthcare agent to speak with the family and stay out of it for a while? I think this, at least in our institution, would cause at least our nursing staff to feel that this violates the patient autonomy and right to self-determination. And it wouldn't be wrong to call in the ethics committee for a consultation, but that might worsen the situation and might cause additional conflict if a short amount of period has gone on. You could encourage the son separately and in separate conversations to represent the patient, but it may be that the son feels as the youngest son that he's unwilling or unable to speak up for the patient. But again, the patient declared him as the agent for a reason. Relational autonomy is a consideration, but it does not overrule this son's, the youngest son's, responsibility of being the healthcare agent. So it is desirable, I would say, to work with the son, the youngest son, and support him in his advocacy to the extent possible. It's possible that a solution could be to legally try to remove him, but this almost certainly would alienate the family, and we know that it is not what the patient wanted. A third-party decision maker is very complex. It's not timely. At least anytime I've been involved, it simply wouldn't work in this situation, and it could be perceived as being overly authoritarian. How do you respect the patient wishes? If the son, the youngest son, was unable to enforce the DNR order with the brothers and the remaining family, even though he could know, he did say that he understood this was not what the father wanted. The providers can step up in this situation, and they could say that this is in fact a medical decision and not really a family decision. Patient autonomy in this situation may be justifiable as an ethical position, but it does not supersede good clinical judgment. So the DNR request of the patient communicated to family in a respectful manner, describing preventing harm as the patient is resisting its treatments. He doesn't want these treatments, and the patient is showing, while he's not able to make decisions, that he's fighting against the things and care that is being provided. He's in distress. So prolonging death as an outcome or improving quality of life by imposing treatments that would not change the certainty of end of life is not necessarily consistent with good care. Based on the discussion with the family and the fact that you tell them that you are not going to resuscitate him, the older son requests a transfer to another hospital. The team, of course, doesn't want to do this, but they do, out of their responsibility and process, do make calls, but there is no available hospital willing to take them in transfer. So in that case, then there's continued support of expressed wishes with respect of the family relationships. Is this a common scenario? Well, I think we do operate and do procedures on patients that have a DNR status. Some may want it temporarily removed, others will want it continued. But we may want to do palliative procedures such as a tracheostomy or gastrostomy. They may have an acute problem like the patient I described. They may have a condition related to the underlying problem, but not terminal, such as a pathologic fracture. And we may simply be providing palliation by decreasing pain or providing vascular access as a way to give additional medications. So this goes across all specialties. There are patients who want and have DNR status, and it really is across all specialties. But the two most common are general surgery and orthopedic surgery. Vascular, urology, and gynecology a little bit left. Now you see that the outcomes are not terrible. 13% DNR patients and almost 6% in non-DNR patients. If we look at, again, what are some other measures, such as 30-day mortality in a different study about 4 years ago, 30-day mortality ranged from 15.5% in orthopedic surgery to almost 30% in colorectal surgery. As you can see, there were many individuals who ultimately did not survive the hospital stay, and in some cases, they had an incredibly long length of stay, and in many cases, did not wish that to happen. We've heard a lot throughout the last couple of days about emergency surgery and the special challenges in emergency surgery. You combine that with older patients, and it is more than a double whammy. Outcomes for patients over 65 years old, which now includes myself, suggests a much higher mortality than would ever be acceptable in elective surgery. And this is in the background of knowing that 25% of patients over 65 years will not survive 6 months, and 50% of those over 85 will not survive 6 months. So how should you discuss emergency surgery with these patients, particularly abdominal surgery? Should it be informed consent? Should it be shared decision-making? And if you haven't heard about best case, worst case consent, you should learn about it, because I think that's the way of modern discussion about the quote-unquote risks and benefits of surgery. Now, what's the practical approach to discussing DNR status? Well, as I said before, uniform policies suspending DNR are inappropriate. There has to be a discussion with the patient or the responsible individual regarding values and goals, and you either have to have a goal-directed, meaning understanding and appointing someone to make decisions in and after the operating room, versus discussion of procedures. How do you respond to potentially inappropriate treatments? Well, implement strategies to prevent conflicts. I mentioned ethics, palliative care consults. Use the term potentially inappropriate or not beneficial rather than futile. That can set up a hostile reaction. Strictly futile treatments should not be provided. You're under no obligation to provide them. And you should always be involved in engagements about when life-prolonging technologies should not be used. What to do if there's intractable conflict between you and a patient's family? Get consultation to continue negotiation during the dispute or resolution. give notice of what that process is to the family, obtain another medical opinion, review whatever policies you have in your hospital, offer transfer to another facility. This is a difficult topic, and I hope I've given you some clue through a case. This is not uncommon. You must discuss the plan around treatment goals. Elderly, frail patients with a poor prognosis at higher risk, and you should have frank, open discussions and family-centered communication. Thank you so much for your attention.